welcome to the session about interventional heart failure treatment. This session is moderated from myself and together with Jae-Joong Kim, and we have lots of panelists here. We start with the first presentation by Jae-Joong Kim, 30 years journey of heart transplantation in Asian Medical Center.
Good afternoon, everybody. I would like to briefly introduce the journey of Asan Medical Center in heart transplantation over past 30 years. I have nothing to disclose. The first heart transplantation in AMC, also first in Korea, was done in November 11th, 1992. The recipient was 51 years old female suffering from advanced heart failure caused by DCMP. And the patient lived for 24 years and died of end-stage renal disease. This young doctor is me. Total 931 and 831 adult and 100 pediatric heart transplantation was done during last 32 years in AMC. And 43 multi-organ transplantation, including 18 heart lung and 10 heart liver, was done during the same period. Year 2000, the Korean network for organ sharing established. After then, the number of heart donors increased and also number of heart transplants increased. 10-year patient survival is around 80% and the 20-year survival is around 50%. And the median patient survival is 23 and the graft survival is 20.7 years. Until now, the longest patient survival was 29.5 years. 32 patients had retransplantation, 5 had early retransplantation, mean 10 days after first heart transplantation, and the etiology was graft failure, either primary or secondary graft failure, and the rest 27 had a late heart transplantation, mean 11.5 years after first heart transplantation, and the cardiac vasculopathy was the main cause in 90% of patients. And the patient survival was excellent. The 10-year survival was 80%. With the increasing number of patients waiting for heart transplantation, the waiting period increased dramatically from a few months to more than years. And the proportion of recipients on ECMO support increased, as shown in data from AMC and data also from Korean Organ Registry data. The post-transplantation survival of recipients on ECMO support at the time of transplantation was significantly inferior compared to without ECMO or with LVAD. This figure showed the cumulative number of heart transplantation in Asan Medical Center during the last 3 decades. Immunosuppression and endomyocardial biopsy protocol has been changed several times according to introduction of a new immunosuppressant and result of clinical efficacy. Before 1999, the main basis of immunosuppression was cyclosporine. So pre-op cyclosporine loading and intravenous use of cyclosporine at ICU and the high target trough level. So with this protocol, AKI often developed during early post-op period. In 1999, anti-interleukin-2 receptor monoclonal antibody and MMF, and in 2007, tacrolimus were introduced to clinical heart transplantation in Korea. So AMC changed the protocol as follows. The main changes were adoption of induction therapy and the gradual increase of CNI and reduced target level of CNI, and also tapering of steroids in low-risk patients. With this protocol, although the patient survival rate was not significantly different, and the rejection-free survival was superior, especially in tacrolimus-containing protocols. AMC begin to use the mammalian inhibitor everolimus in 2009 as de novo therapy. De novo means starting everolimus at 2 weeks after transplantation, or in case of CKD or CAV. The everolimus showed a little better composite endpoint, although statistical is not significant. This is currently being used immunosuppression protocol in Asan Medical Center. The main change is early use of mammalian inhibitor and the use of thymoglobulin as induction in immunologically high-risk patient and the steroid withdrawal. Randomized biopsy protocol also has been changed from very frequent biopsy, especially during the first 2 months after transplantation and the annual surveillance biopsy, to reduce the number and delay the first biopsy at 4 weeks of transplantation and no annual surveillance biopsy. In case of CMV IgG positive donor and positive recipient, Asan Medical Center adopted the CMV prophylaxis rather than CMV preemptive therapy as following protocol. But with this protocol, segmental neutropenia often developed, so changed to low-dose prophylaxis protocol. As can be seen, the Kaplan-Meier cumulative event curve for freedom from CMV infection and CMV disease, the low-dose prophylaxis is similar efficacy compared to higher-dose prophylaxis. The cardiovascular is the main obstacle to heart transplant patient live longer. So the Asan Medical Center introduced intravascular ultrasound to diagnose the CAV in 1997, and it is still being used for detection and decisional treatment. And recently, several invasive and non-invasive protocol diagnostic method are used. And as a prevention and treatment, everolimus began to start in 2009. This slide shows the vascular remodeling pattern after heart transplantation. As you can see, this figure, the plaque volume increased significantly after 5 years, but vast volume significantly decreased during first year. This negative remodeling is known to contribute to CAV development. The everolimus as de novo immunosuppression showed the least increase of plaque volume, least decrease of vast volume, which contributed to least decrease of lumen volume. In this study, more patients included, and the follow-up duration increased. In the left figure, and everolimus showed achieved the least acerbic volume increase. And in the right figure, everolimus showed posterior remodeling consistently up to 5 years, but others showed incomplete or negative remodeling. CAV involves not only epicardial, but also intramyocardial arterial. So normal-looking cholangiogram, the myocardial perfusion can be reduced. So combination of coronary CT angio and the CT myocardial perfusion image could increase the specificity and sensitivity for CAV detection. Until now, no patient have lived more than 30 years in Asan Medical Center. The cause of death after 20 years is malignancy infection and the CAV. How to improve patient life longer than 30 years? If we prevent malignancy and CAV, the patient median survival increased to 24 years. More importantly, around 30 of patients can live longer than 30 years. This is current AMC strategy for prevention, diagnosis, and treatment of CAV. Key element is the use of statin, aspirin, and mammalian inhibitor as early as possible after transplantation, and early detection with invasive and non-invasive method and timely treatment is very important. So the journey of Asan Medical Center toward better survival and better outcome will continue, and the heart transplant patient lives will be better and longer. Thank you for your attention.
Thank you very much. We will have discussion after the first 3 lectures. So the next one will be Young, Hoon, Yang, and the title is Cardiogenic Shock in Korea, Perspectives After the ECLS-Shock Trial.
Thank you, Mr. Chairman. I'm Yang from Samsung Medical Center. Today my topic is cardiogenic shock in Korea, perspectives after the ECLS-Shock trial. This is my disclosure. In real-world practice, 50 to 60% of patients survive without any MCS. In this group, inserting MCS will have no impact on survival, no survival, and may lead to some complication by device itself, resulting in death. 40 to 50% of patients do not survive in this group. There are some futile situation where MCS application did not benefit in this situation, such as brain death and sepsis. So 15 to 25% of patients may be optimal and appropriate candidate for MCS support. So adequate patient selection and timing are very important to improve clinical outcome. Recently, 2 randomized controlled trials of mechanical circulatory support were published. One is ECLS-Shock trial, and the other is Danger Shock trial. This slide showed a quick summary of both trials. In ECLS-Shock trial, started in 2019 and was conducted until 2022, whereas the Danger Shock trial started in 2013, were enrolled for more than 10 years. The primary outcome in ECLS-Shock trial, death from any cause at 30 days, whereas the Danger Shock trial, death from any cause at 6 months. There was no significant difference in primary outcome in ECLS-Shock trial. However, the application of impeller was associated with improved clinical outcome in Danger Shock trial. Interestingly, the mortality rate of conventional therapy in ECLS-Shock trial only 49%, but Danger Shock trial and 49%. This discrepancy will have influenced the result of post-clinical trial. In post-clinical trial, bleeding and vascular complication occurred more significantly in MCS group than standard therapy alone. Today, I'd like focus on the ECLS-Shock trial. As you know, the 420 AMI with cardiogenic shock for whom early revascularization were planned, were randomly assigned to early ECLS plus usual medical treatment versus usual medical treatment alone. As you know, that there was no significant difference in primary outcome, so ECLS-Shock trial failed to show the benefit of VA-ECMO. Why? Why is ECLS proved not beneficial in the ECLS-Shock trial? First reason is too late initiation of ECLS. In this trial, ECLS people revascularization is only 22%. both observational trial, our trial showed that the early application of ECMO, such as before revascularization, was associated with improved clinical outcome. A second reason is that the enrolled patient were severe futile. The 95% of patients had altered mentality. 78% received CPL before randomization. 24 patients had poor neurologic outcomes. Third reason is high complication. Bleeding and ischemic vascular complication occurred significantly more in ECLS group than standard therapy alone group. I think that it is critical to reduce device-related complication per positive trial related to mechanical circulatory support. This is our study regarding to reduce limb ischemia in ECMO patients. In this study showed that the smaller arterial cannula size, for example, 15 French, was associated with reduction of limb ischemia. This is another study regarding reduction of limb ischemia. As you can see here, fluoroscopic guided simultaneous distal perfusion can reduce distal limb ischemia in ECMO patient. In respect of bleeding, in ECLS-Shock trial, more than 70% of patients receive a potent P12 inhibitor. In our data, potent P12 receptor inhibitor was associated with increased bleeding in ECMO patient. And this is a post-closure technique. The percutaneous cannula removal with ProGlide can reduce bleeding complication in ECMO patient. Fourth reason is that LV unloading was performed in a limited patient of ECLS group. And actually, ECLS group is only performed in 6% of study population. And recently, LV unloading trial, randomized control trial, two randomized control trial conducted from South Korea and Jeonnam National University Hospital and Asan Medical Hospital. Two trial did not improve clinical outcome in ECMO patients. So the routine early LV venting is not beneficial in ECMO patient. We are able to run the following point from ECLS-Shock trial. Although overall mortality was similar in both groups, the trial revealed meaningful increase in safety endpoint, bleeding, limb ischemia, sepsis, and kidney injury in the ECLS group. These findings highlight the substantial importance of the critical care of patients after the implication of MCS, the opportunity to further improve clinical outcome with the development of strategy that might reduce disease morbid complication both through clinical practice and continued device innovation. In our hospital, CISU adopt a high-intensity stepping model by dedicated cardiac intensivist, and ICU-based physician assess all patients admit CISU, are responsible for all aspects of patient care. Our multidisciplinary team consists of one cardiac intensivist, one general cardiologist, one general intensivist, three senior residents of internal medicine, nutritionist, pharmacist, respiratory therapist, and RN and AN. After the implication of a multidisciplinary team approach, including a dedicated cardiac intensivist. The in-hospital and CICU mortality was dramatically improved, which driven by non-cardiac deaths, non-cardiovascular deaths dramatically reduced. This result published in JACC. And this is another study regarding the role of human resource in cardiogenic shock field using Korean National Health Insurance Service database. ICU nursing staffing power, grade 1, was associated with improved short-term and long-term clinical outcome in cardiogenic shock patient. Skip. Lastly, I'd like to introduce a randomized controlled trial regarding the optimal revascularization of multiple disease in AMI shock underwent VA-ECMO. This is my perspective on revascularization in AMI shock patient. It is unclear whether the low immediate multiple PCI differed for an extremely advanced form of cardiogenic shock underreported in the corporate shock trial. In the clinical role of non-corporate lesion revascularization may be different from the other MCS, such as impeller, capable of LV unloading, because VA-ECMO may induce pulmonary edema along with increased LV filling pressure by increased afterload. It may result in aggravation of the ischemia in non-corporate lesion territory and delayed cardiac recovery, leading to failure of ECMO weaning. This is my study, a shock trial for comparison of clinical outcome between multivessel PCI versus corporate-only PCI in AMI shock who underwent VA-ECMO. We will enroll 506 patients with AMI patient. Primary outcome is 90-day all-cause mortality or cardiac replacement therapy, such as LVAD or heart transplantation. Contrast to the multivessel PCI of the corporate shock trial. In case of CTO, as a non-implanted artery revascularization attempt is only left in operative discretion, not highly recommended. I hope that this trial will deliver the valuable information to Society of Cardiovascular Intervention and ECMO Society. Thank you for your listening.
Thank you very much. Next one will be Nicolas van Mieghem, and his title is Pulsatile Mechanical Circulatory Support, When and How.
Thank you very much. Ladies and gentlemen, I'm going to talk about pulsatile mechanical circulatory support, and I'm going to highlight two different devices. One is the conventional intra-aortic balloon pump. The other one is the IVEC2L by PulseCat. And I think the previous speaker already mentioned the importance of timing when we want to apply mechanical circulatory support. Whether we are talking about cardiogenic shock or high-risk PCI, what you want to do with mechanical circulatory support is you want to anticipate worse events during an incident. If needed, you need to escalate. And then you have to choose wisely. Not every mechanical support is appropriate in each situation, so you need to choose wisely. And also you want to minimize inotropic and vasopressor support. So if we specifically focus on intra-aortic balloon pump and we focus on cardiogenic shock, then I think we have two randomized controlled trials by Holger Thiele that suggested that there is no place for intra-aortic balloon pumping in the context of cardiogenic shock. We are very familiar with IBP shock 2, but also in culprit shock, which was focusing on the treatment of coronary disease or multivessel coronary disease. But also balloon pumping was applied in that trial. So if we look at culprit shock and IBP shock, out-of-hospital cardiac arrest was present in more than 40 to 50% of the patients, and that is also a lesson learned from the ECLS-Shock trial, that CPR is maybe a specific set of patients, and I wonder whether we should not exclude those patients from these randomized controlled trials, and probably that is one of the advantages that we saw from the DanGer Shock trial, where CPR patients were excluded if the patients were not awake upon arrival in the hospital. I think also the fact that patients were on high-dose catecholamines prior to randomization is also driving the outcome of these patients. And in IBP Shock 2, and this is an important one, only the smallest balloon pump size was used in a German population that is obviously quite a larger population. And IBP size matters, and this is data from Naveen Kapoor, where he compared the 40cc balloon pump with a 50cc balloon pump. Turns out that the 50cc balloon pump will dramatically have more responders in terms of unloading, systolic pressure unloading, but also diastolic augmentation will be more pronounced with a larger balloon. So basically, use the larger balloon when you consider intra-aortic balloon pumping, because there are some identities and clinical situations where the balloon pump seems to work. And this is a overview paper by Baldetti that also we contributed to. And he identified a set of clinical entities where balloon pumping might still be useful. And this is when patients have a shock, you want to avoid the dramatic shock. So you can have a depressed cardiac index, but it should be, the cardiac power output should be above a certain value. The same thing for RV function. You don't want to have severe RV dysfunction. Balloon pump will not work in that situation. Same thing with increases in left-sided pressures, filling pressures, but if the filling pressures are too high, the balloon pump is just not powerful enough. So there is, and also patients who are tachycardic, also there the balloon pump will be less effective. So I think there is a sweet spot where balloon pump can work, and this is a pilot trial that we conducted in Erasmus a couple of years ago, where we randomized patients to either balloon pump or inotropic support. Those patients were in a decompensated heart failure state with a proven low cardiac output. Patients all had right pulmonary heart catheterization, and patients were then randomized to the 50cc balloon pump versus inotropic support. The primary endpoint was an increase in mixed venous saturation at 3 hours, and there was a, well, definitely balloon pump was outperforming inotropic support. And also, if you look at the cumulative fluid balance, it was more negative with balloon pump than with inotropes. So that was, for us at least, an argument to consider balloon pumping in a new randomized controlled trial, talking about patients in SKY B, maybe early SKY C. So you don't want to have the full-blown cardiogenic shocks, but you want to have those patients who are on the verge of entering a cardiogenic shock, pre-shock if you will. Those patients, we are looking for 400 patients, will be randomized 1-to-1 to either balloon pump or standard of care. And then we have a follow-up out to 30 days and 1 year. This trial, this is a randomized controlled trial that is about to start in spring this year. Then switch from cardiogenic shock to high-risk PCI. And now we're talking about a different clinical situation. We're not talking about SKY B or C, but we're talking about SKY A, patients who might be at risk of developing hemodynamic compromise during a high-risk PCI procedure. In that situation, balloon pump is also not effective, but another mechanical circulatory support system that is Pulsatile, the IVEC2L, might be very effective. And this is a device that is inserted through the common femoral artery. It's connected to an extracorporeal pump, and the tip is residing in the left ventricle. There's a bidirectional pump, and the whole system is driven by a conventional intra-aortic balloon pump console. And so triggered with the cardiac cycle, during systole, blood will enter the system, will be sucked into the pump, and during diastole, there will be a diastolic augmentation with the expulsion of blood into the ascending aorta. So basically, you expel blood from the LV into the ascending aorta, synchronized with the cardiac cycle. And so IVEC-2L is basically a different animal than an intra-aortic balloon pump. As a matter of fact, it is an intra-aortic balloon pump on steroids, where an intra-aortic balloon pump can generate approximately 0.5 to 0.6 liters per minute support, depending on the state of the heart and the patient. IVEC-2L will give you 1.5 to 2 liters per minute pulsatile cardiogenic support, and this will have immediate effects on stroke volume and stroke work that are more pronounced than balloon pumping, and you can see also immediate unloading of the ventricle with an IVEC-2L that is hardly present with an intra-aortic balloon pump. So this is also illustrated from the PV loops here. This is real-world data where you see a shifting of the PV loops to the left and downwards, meaning LV unloading. I want to briefly mention the PULSE trial. This was a prospective study, non-randomized, where patients that underwent high-risk PCI also got continuous PV loop measurements during MCS support with the IVEC-2L. Patients were a mean age of 74 years old. We had 29 patients. Of those 29, 27 had PV loops that were eligible for evaluation. And it turns out that of those patients, 22 were responders in terms of LV unloading, immediate LV unloading. 5 patients were non-responders. And this is not a surprise that you will have non-responders, because the patients were entering a high-risk PCI procedure and they were euvolemic or hypovolemic when they entered the cath lab. These patients were not in cardiogenic shock, were not decompensated. So those were elective high-risk patients, and still we were able to find LV unloading. And this is for us then the rationale to continue with the PULSE 2 randomized controlled trial, where in patients with undergoing high-risk PCI, requiring mechanical circulatory support, patients will be randomized 1-to-1 to either the IVEC-2L or the Impella CP. So in conclusion, I think that mechanical circulatory support is a valuable tool in high-risk PCI, but it's difficult to prove, as it is most often will run only in the background. Oftentimes, you will have the mechanical circulatory support in place, but the patient will remain stable throughout the procedure, but you just want to have it just in case. Timing and LV filling is the key to demonstrate LV unloading. So it's difficult to demonstrate LV unloading in completely stable patients. So for instance, if I would put in any mechanical circulatory support in most of us today, it will be very difficult to demonstrate unloading because we are hypoto-euvolemic. IBP may still be effective in selected patients with early hemodynamic compromise, not in overt cardiogenic shock. And in terms of pulsatile MCS, the IBP may not be potent enough in severe hemodynamic compromise. The PulseCat IVEC-2L is a more potent device and may be effective in high-risk PCI, and new randomized controlled trials are kicking off this year. Thank you for your attention.
Thank you very much. We have a couple of minutes for discussion, and let's start with the panelists. Any comments or questions to one of the lecture speakers? If not, Nicolas, your new device, the IVEC-2L or L2? 2L? So, I mean, I clearly can see that, to my understanding, that is better than IBP. But in relation to Impella, I mean, this is same size of French, right? 17 French?
It's 17 French, so it's somewhat larger than the 14 French Impella CP. But the difference is that the IVEC-2L provides you pulsatile support, whereas the Impella gives you continuous flow support. So 3 liters per minute continuous throughout the heart cycle is different from 1.5 liters pulsatile support. As a matter of fact, if we looked at our PV loops in the PULSE trial, they are more or less similar to what you can expect from unloading with an Impella CP. The difference is that with the Impella device, there will be no longer isovolumetric relaxation and contraction phases that you still see with the pulsatile support.
I may be able to understand that's important for patient cardiogenic shock. But for PCI, high-risk PCI, is that important?
Well, again, I think it's very difficult to demonstrate benefit of mechanical circulatory support in high-risk PCI, right? Because you only want the device to kick in when the hemodynamics are falling. We feel that at this point in time, IVEC2L is not ready for cardiogenic shock treatment because you cannot keep it in situ for more than 24 hours because of the 17 French size. If you would want to consider that, you also will have to insert an antegrade cannula as we do with ECLS, and that might be a bridge too far.
And the decision for the comparative arm against Impella versus non-support or a balloon pump?
Well, so that, again, it's very difficult to demonstrate the clinical benefit of mechanical circulatory support in a randomized control trial. So that would not be the purpose of the study with the IVEC2L, but we are all familiar with cases where the Impella saved the day during a high-risk PCI case. So we don't, that is basically the main argument.
I'm not familiar with, I haven't seen this device, but stability and hemolysis, are those problems with that device?
No. So hemolysis is not a problem in terms of stability. The device itself is very stable. It sits stable in the ventricle. I think the major issue there is the 17 French that precludes the use in an ICU setting.
Is that something that technology can solve, that big size?
Well, we have been talking with the engineers there. It is now converting to a sheetless system. So a sheetless insertion, basically something similar that we have with the Evolute system, and then you will become a 14 French equivalent technology.
Because all these devices are limited by vascular and limb complications.
Yeah, exactly.
And this device will not be able to give complete support in case?
No. So this is a very important statement. So if there is zero output, obviously a balloon pump will not help you. So
Any other, maybe a question to my co-moderator. I saw that your number of transplant has increased until the year of 2017, 18, and then it's stable or sometimes declining. Is that lack of donors or is it a lack of patients?
In Korea, the number of donors is not declined. This is the number of donors is steady state after maybe 2020. But the number of transplanted center is increased. Maybe 20 years ago, the number of transplant center is only about 5 to 10. But nowadays, last year, is more than 30. Center is doing heart transplantation. So the Asan Medical Center's number of transplantation is
And what's happened to your LVAD numbers during that period?
So number of center? Yes, in Korea, the criteria is not strict to do heart transplantation. So many centers want to do heart transplantation, so they are prepared to satisfy those criteria, and they get certification, and they are doing heart transplantation.
So is the number of transplants in the entire country increasing or stable?
Yes.
It's increasing.
Yeah. So last year is around 220 heart transplants were done in Korea, but 10 years ago, maybe it's around 150. It's now the total number of heart transplants is increasing in Korea.
Do you do assist devices as well at Asan? Left ventricular heartmate assist devices?
System?
LVAD?
Yes.
Is that? Well,
It's the one of the reason for increasing the number of heart transplant centers. 2018. And LVAD, the national insurance system is reimbursed the LVAD for advanced heart failure. After then, the LVAD patient is increased, and also number of heart transplant increased. Also, the number of heart transplant centers increased.
So I had a question for Dr. Yang about his randomized trial on ECLS and multi-vessel revascularization. So how do you gonna design the study that is different from ECLS-Shock? Because obviously in that trial also a lot of patients were having or had multi-vessel coronary disease. Are you excluding CPR patients?
No, no. I included arrest patient. I only excluded out of hospital cardiac arrest with GCS score less than 8.
But the ECMO happens before the revasc, doesn't it, as opposed to ECLS? Is ECMO always before revasc?
No,
Oh, okay.
yeah, right. All enrolled patient already underwent VA-ECMO.
So that's a key distinction from the study. They get the support early.
Yeah.
And do they all get a vent strategy or not? An LV venting strategy? Or
Every venting strategy and distal perfusion catheter were also wrapped in operator discretion. And I have one question. The impeller device and IVEC device were not available in South Korea. And I think the major weakness of IVEC is durability. I know the duration, maintenance duration is only less than 48 hours.
Correct.
So we cannot use IVEC in advanced cardiogenic shock patient.
I totally agree with that. So I think IVEC-2L at this point in time is only for high-risk PCI. Yeah.
So Dr. Nicolas, you said that you wanted to use them in pre-shock patients. So clinically, how do you really recognize these pre-shock patients?
So it's a balloon pumping then.
Okay.
Yeah.
So because getting a right heart cath done in these kind of patients is not always easy. You don't get your cardiac power outputs, your PC wedges, and etc. So are you looking at just lactates, or I mean, what is your
Yes.
What is your criteria for pre-shock?
Yeah, so there are multiple, there's a whole series of, whole listing of criteria that we would follow, but in the context of the trial, we would recommend a low threshold for Swan-Ganz catheterization, because obviously that is an important discriminator to discriminate SCI B from SCI C shock. Yeah.
Is there a cost difference between Impella and IVEC?
Oh yeah. So
Much cheaper?
it's more than 50% cheaper. And again, the IVEC-2L is driven by your conventional balloon pump console, so it is very intuitive to work with.
We can now move to second part, and the first lecturer is Hanbit Park from Korea, and his topic is LV unloading after VA-ECMO, routine versus optional.
Thank you, Chairman. I am Hanbit Park from Gangneung Hospital. Today, my topic is LV unloading after VA-ECMO, do routine or do optional. This is my disclosure. Let's see the first pulmonary effect of VA-ECMO. After started ECMO, RA pressure is decreasing, but however, mean aortic pressure is increasing, and increasing mean aortic pressure makes increased afterload. But if LV contraction cannot overcome this increasing afterload, it makes the blood LV distension and blood stagnation, and increase the LV EDP. Increased LV EDP makes transmit to LA, and LA pressure increasing, and PCWP increasing, and it makes pulmonary congestion. So LV distension makes some complications during VA-ECMO. First, intracardiac thrombi, and second, refractory pulmonary edema, third, refractory ventricular arrhythmia. And LV distension is occurred about 30% of during VA-ECMO. LV distension makes delayed myocardial recovery, and delayed myocardial recovery may need transition to LVAD from ECMO. So in daily practice, we perform the LV unloading to decompress this LV distension. Currently, the several elbow undering procedure was performed. Transaortic pigtail and IABP and pulmonary artery cannulation and arterial septostomy, but just a partial elbow unloading. And transaortic elbow cannulation and impella and transseptal elbow cannulation and tandem can complete unloading. However, in Korea, impella is not available, so we usually perform transseptal elbow cannulation during VA-ECMO. Let's see the timing of previous study about timing of elbow unloading. First, in Asan data from Asan Medical Center, total 124 patients was enrolled. The transseptal elbow cannulation increased the rate of ECMO weaning, but not in hospital mortality. Second, data from Australia, elective decompression of the elbow unloading in pediatric patients may reduce the duration of VA-ECMO. Third, data from Europe, elbow unloading is associated with the lower mortality in cardiogenic shock treated by ECMO. Its early unloading is also associated with favorable outcome. The last data from Samsung Medical Center from Korea, the prophylactic elbow unloading was associated with a lower early mortality rate compared with the therapeutic elbow unloading. In current evidence, early elbow unloading treatment was associated with favorable clinical outcomes such as mortality and weaning of VA-ECMO. However, the previous studies that were observation study, the level of evidence was low. So non-randomized observation studies may have significantly affected the result owing to potential selection bias. Essentially, the two randomized control trial from timing in timing of elbow unloading from Korea. The first is ECLS-Shock trial in Asan Medical Center, and second is early unload trial in Jeonnam National Hospital. That's the purpose of the ECLS-Shock trial. ECLS-Shock trial is a randomized control trial to compare the early LA venting strategy and conventional venting strategy in cardiogenic shock patient. Total 60 patients was undergoing VA-ECMO in refractory cardiogenic shock, and one-to-one randomization, and primary endpoint is weaning of VA-ECMO. The study endpoint, primary endpoint is the rate of weaning from VA-ECMO during index admission, and second endpoint is the rate of mortality, and successful heart transplantation and LVAD implantation, and duration of mechanical ventilation, and improved pulmonary edema, and any other adverse event related to VA-ECMO. The trial process, we performed the LV unloading procedure is transseptal LA cannulation during VA-ECMO. Time to LV unloading, early group is 2.4 hours, conventional group is 48 hours. The baseline characteristic, early group and conventional group are well randomized without difference. And in clinical outcome, the primary endpoint is weaning of VA-ECMO. Early group and conventional group was not differenced. And mortality and duration of ECMO and mechanical ventilation and duration of mechanical ventilation and hospitalization was not different between two groups. And adverse event related to VA-ECMO therapy is stroke and cardiac tamponade and puncture site bleeding, GR bleeding. The image case was not different between two groups. So this study conclusion, early LV unloading strategy did not increase the weaning of rate of VA-ECMO compared with the conventional approach. These findings therefore do not support the systematic use of early LV unloading following VA-ECMO insertion. However, this trial was underpowered and inconclusive because of small sample size and study design. For larger scale studies, will thus be essential to establish the optimal timing of LV unloading during VA-ECMO. Second, early unload trial from Jeonnam National Hospital. Total 118 patients, cardiogenic patients was enrolled. Early LV unloading with 12 hours versus conventional approach. Using mortality of is same, the transseptal LA cannulation. Time to LV unloading, early group is 1 hour and conventional is 21 hour. Study endpoints, primary endpoints all-cause mortality at 30 days, and secondary endpoints composite of all-cause mortality, transseptal cannulation, and cardiac, non-cardiac death, and immosphere mortality, and rate of VA-ECMO weaning. Baseline characteristics and early group and conventional were well randomized. However, without ischemic disease, more in conventional group. And post-prime endpoint local mortality was not different in between early group and conventional group. And clinical outcome, all-cause mortality and cardiac death and inheart death and weaning of VA-ECMO and weaning from Mieghem ventilator was not different between two groups. And adverse event and clinical ischemia infection and stroke and bleeding was not different. So this is the conclusion. Among patients with cardiogenic shock undergoing VA-ECMO or routine LV unloading with transplantation and attenuation did not reduce 30-day mortality and compared with the conventional strategy. Further extensive study using other unloading modality are warranted to investigate the efficacy of early routine LV unloading. This is my next slide. In summary, peripheral VA-ECMO has an inherent limitation of increasing LV load and subsequent pulmonary congestion. Several mechanical circulatory strategies can be used to achieve LV unloading if conservative measures prove to be insufficient. Many data indicate the benefit of LV when overt complications of increased afterload are developed. And these two RCTs did not support the systematic use of LV unloading prior to VA-ECMO. Further larger scale trials using other unloading modality are warranted. Thank you.
Thank you for your lecture. I move to the next lecture. The lecturer is Chul-Min Ahn from Korea, and this topic is mechanical circulatory support related to limb ischemia, how to prevent and rescue.
Thank you, Chairman. So my topic was some mechanical circulatory support related to limb ischemia prevention and rescue. So I have nothing to disclose. And the complication of ECMO was, so various complications was some noted. So usually limb ischemia was a very terrible some complication in patient with ECMO. In our data shows that there are still some increasing the survival of the ECMO. The patient was some condition was more aggravated previous conditions. And then vascular access, maybe the limited, some relative contraindication in patient with ECMO. And then PD was now more increasing some aging process. And then you previously, Dr. Yang mentioned that the cannula catheter was related with the complications. So we usually done 15 to 16 French of the artery for some arterial cannula, and vein was 21 French. And if the catheter was inserted the same side, the more complication maybe occurs. In our some short cases, it's not my patient. So initially, he admitted with due to the polypectomy, and after the 1 hour polypectomy, the patient was suddenly collapsed and cardiac arrest was occurred, and we some VP and then CPR for 1 hour, and the ECMO was inserted to invest this patient, and coronary angiogram shows it's acute elevation myocardial infarction in large RCA territory. And after 1 hour, the patient was patient color, leg color was very aggravated, and to POD 8. So we inserted already some distal perfusion catheter, but the patient condition was aggravated. And so finally, the patient was amputated. After these cases, we inserted all patients simultaneously with some ECMO catheter with distal perfusion. So limb ischemia was up to the 40% of some patient with ECMO, and risk factor usually femoral, some percutaneous cannulation with absence of distal perfusion, and ipsilateral venar artery was used in patient by ECMO, and young age and female and vasculitis was more some bad outcome factor. And 3 was always some considered for some VA and ECMO, and access site was usually some approached by some ultrasound guided punctures, and some cases the lower some bifurcation site. So and upper we needed imaging guided procedure for some large femoral cannulation. and that was much different, some ultrasound guided puncture or not. So that guideline in large bore cyst procedure, we needed the ultrasound guided puncture. And then some large bore catheter was can make some injury to the external iliac artery, like denudation of like this. So we inserted the gently inserted the catheter of large bore cyst. And in some cases, the common femoral puncture site closure can make some occlusion by this. So we should cautiously step hemostasis for ECMO-related problem. Another was inflow. So inflow disease was very crucial for the ischemia. So inflow disease had very difficult to prevent in patient with ECMO. However, we should consider the in PAD patient, in elective cases, we use the other route of some excess. And then in large bore cyst procedure, the cyst to femoral artery ratio over the 1.00 was make a more vascular complication. So you needed some CT for some inpatient with elective cases. And outflow also very important. So this perfusion catheter we use is usually 6 to 8 French catheter of cyst, and the small caliber can make some surgical conduit if the patient was possible. And also some hemodynamic some assessment was needed after some inpatient with ECMO patient, but it is very difficult to assess in ICU setting. And some Kelly scores can predict the limb ischemia Sievert score. So that over the 2 points of the patient evaluation, that was a high risk of some limb ischemia. So that was my elective cases. I usually insert the vascular cyst. Before the vascular cyst, I inserted distal perfusion puncture first, and then inserted some retrograde cyst, and the antegrade cyst also inserted. And then we connected the main ECMO catheter. So if the patient was available, so I think initially some inserted antegrade cyst was needed for some patient some prevention of distal ischemia. So it's our registry, Korean registry data. So in patient of some ECMO, the prophylactic distal perfusion catheter insertion group and not insertion group compared to the mortality, that was a significant difference. In 30 days mortality in patient without distal perfusion catheter insertion. So we always needed to insert some distal perfusion catheter. So initially, assess the patient of conditions. The distal perfusion catheter insertion was always needed. And take-home messages: the peripheral artery is a critical issue in MCS, and exact access and light placement catheter was essential. And open conversion or urgent procedure if a complication was suspected, and the prophylactic distal perfusion catheter insertion was necessary for patient of poor distal perfusion. Thank you for your kind attention.
Thank you for the lecture. Now move to last lecture. And the lecturer is also Sievert, and this topic is endovascular papillary muscle approximation, a novel approach for heart failure treatment.
Yeah, thank you very much. So we started with devices which are older than most of you, and now we're coming to a technique which is younger than most of your children and grandchildren. So it's a pure experimental therapy at this stage. The background of that is that as you all know, geometric dislocation of the papillary muscles is part of a vicious circle in heart failure patients. So it starts with LV dilatation, then there's papillary muscle displacement, leaflet tethering. Some of these patients develop FMR, but most of them don't. But it reduces the ejection fraction and results in further LV dilatation. And this displacement of the papillary muscles has not been a target yet by catheter-based procedure, but it has been a target of a surgical procedure, which is the surgical papillary muscle sling procedure, which means placement of a Gore-Tex tube around the papillary muscles. The goal is to reshape the ventricle in order to improve LV function, and typically the sling procedure is combined with ring annuloplasty to treat mitral regurgitation. So the surgeon is repairing the mitral valve, and then during this operation, they insert this Gore-Tex tube in order to approximate the papillary muscles. This has been, the surgical technique has been tested in a randomized trial. So in addition to mitral valve repair, they applied the sling procedure, and you can see beneficial effects on MR grade, of course, but also ejection fraction, LV-EDD, pulmonary systolic pressure, and mitral tenting. All these differences had been significant. Now, the V-sling concept tries to achieve the same by a transcatheter technique. So we go from the artery, insert a big cannula into the left ventricle, encircle the papillary muscles, and implant basically a Gore-Tex tube in order to approximate the papillary muscles. This has been tested in acute and chronic animal trials, transcatheter approach in animals. You can see histology here. You can see this has also been tested in human cadavers. So we went into human cadaver and encircled the papillary muscles here, and this is a result after the implantation of this Gore-Tex tube. The current ongoing clinical trial includes patients with ejection fraction between 20 and 40. Severe FMR is excluded. NYHA class 2 to 4A. LV end-diastolic systemic more than 55 is an inclusion criteria, and cardiomyopathy of ischemic or non-ischemic origin. We exclude, as I mentioned before, patients with mitral valve replacement, of course, any evidence of structural mitral lesions, severe aortic stenosis, and severe tricuspid regurgitation. You can see the results in the first 3 patients where we were successful to implant the device. You can see improvement in quality of life. You can see improvement in 6-minute walk distance and improvement in some of the patients regarding ejection fraction. Case example, 57-year-old male patient, dilated cardiomyopathy, heart failure class 3, 1 heart failure-related hospitalization in the past year, ejection fraction 29, and MR 1+. In order to plan the procedure, we use CT assessment, echo measurements. We test this in a virtual planning, in a computer model, as well as in a physical model before we start with the case. We define where we want to go around the papillary muscles. We mark this on the screen later on. And here you can see one of these procedures. You can see the LV angiogram. We make a drawing on the screen, so it's kind of, high sophistic imaging overlay. The catheter is now in the left ventricle. We insert the encircling catheter, which goes around the posterior papillary muscle. And when we find our way, then we went onto the anterior papillary muscle, and then the wire is inserted. The sling, in order to grab the wire, is coming from the lumen of the big catheter. Now the encircling wire leaflet is created, and then the device is advanced over that encircling wire, and finally the muscles are approximated. You can see this here on echo at the same time. Here's the structure bringing the papillary muscles together. So this is pre-procedural. This is 30 days after the procedure. And this shows you an example of CT imaging before and up to 6 months after the procedure. So in summary and conclusion, the sling procedure is a surgical technique to approximate the papillary muscles to treat heart failure, proven to be effective in HFrEF patients. The transcatheter V-sling procedure is feasible. It resulted in symptomatic improvement, quality of life, and 6-minute walk distance, improvement of the ejection fraction. The procedure does not block any other future interventions. This may become a treatment option for HFrEF patients, and the first main trial is ongoing. Thank you very much for your attention.
Thank you for your lecture. Now the panel discussion will start. And so, any questions, comments from panel?
That was incredible, Horst. Do you envision that this could turn a mitral FR patient into a CoAF patient once you reduce the dilation? And Would you then do TEER? if they had
Currently, the
residual?
concept is not to treat MR with these, although the surgeons do it, but they do it in combination with mitral valve repair. So that means they eliminate the MR, and then in addition to that, they do the sling procedure. And that is currently concept what we are following. So we are not treating MR patients. That's not the
But do
goal.
you envision if you would then maybe do TEER if they had residual MR after you did the,
Well, actually, we could envision that we do both, that we
Yeah.
do mitral clip, and then in addition to that, the sling procedure. So the other way around. First, like the surgeon, eliminate the MR, and then treat the ventricle.
Wow, but you can imagine that you would first do the sling and then improve the coaptation, get a better grasp, and then capture more tissue. So I think
Yeah.
this is part of what Marty in his keynote this morning mentioned about the toolbox, right? Eventually, we will create a toolbox of techniques to treat FMR and even DMR. But a brief question for you, Horst. If you compare this to AcuCinch, CoreCinch, is it simpler?
Well, currently for me it's more difficult, but I have done a couple of cases, 5, 6 cases. So it's pretty difficult, and we are improving the technique. So we are learning. We also improved the catheter. We started with a thin catheter, now it's a thicker catheter. So it's still very, very early. So I cannot say whether it's easier or more difficult than the AcuCinch.
And
it's too early.
The rate limiting step is to get beyond the papillary muscle and
To find the right channel.
yeah,
So
yeah.
there are so many trabeculars, much more trabeculars in humans than in animals. So it's more difficult than in animals.
Dr. Horsberg, so there are some variations in papillary muscle anatomy. Is there any obstacles? And also, what is the potential kind of adverse event in your...
So we analyze each individual patient, and we exclude currently many patients because there's no good pathway. So we want to see on CT and on echo that we have sufficient papillary muscle which can be encircled. So it's a difficult process currently.
I have a question. Every dilatation is kind of pathology in dilated cardiomyopathy, but it's also a compensation mechanism. So if we reduce the size of LV, the ejection, even though the ejection fraction goes up, but the cardiac output can be decreased. So I have a concern about the decrease in cardiac output in the case.
Well, I mean, our numbers are too small to say anything in that regard, but when you look at other techniques, there was the MyoCore device and others which reduced the diameter of the LV, so that was beneficial in these trials. And one of these trials was actually a randomized trial, so I'm not so much concerned. I think the dilatation in these patients is more than what is needed for compensation, and that's part of the disease.
I have one question for you. So during the procedure, are there any some risk of related arrhythmia? You know, the catheter or the wire can be.
That was not
provoked.
a serious problem. No, you could have. We anticipated that, but we didn't cause some extra beats, of course, but not severe. No ventricular fibrillation, something like that.
Okay, I have 2 questions for you. Is there any cases that mitral regurgitation is aggravated? And second question is, what is the endpoint of the procedure? How much does it have to be approximated?
We don't know. I mean,
Yeah.
we are still struggling to make it feasible. It is feasible, we know that, but all other information is much too early. We didn't see any patient with worsening MR, so that's not a problem.
I had a question related to the venting strategy with the ECLS. In Korea, I have the impression that the go-to approach is to do a transeptal puncture and put a catheter. Is that correct?
In Korea, I already said that the impeller is not available in Korea, so we approach it to femoral vein and transeptal LA cannulation and catheter in drain to LA to ECMO flow.
Yeah. But you would not consider balloon pumping for venting?
Balloon pumping is not effectively LV unloading, so we thought and another arterial approach is needed. So we usually the safe procedure in LA septal cannulation, LA cannulation is safe and common procedure. So we performed usually LA transeptal LA cannulation to unload the LV.
Well, I think one key is how pulsatile is the patient. If they're not pulsatile, the balloon pump's not going to do much. And that may be one thing that the trials did distinguish pulsatility on effect on venting strategy.
So it is still our go-to venting strategy in Rotterdam because it's only a 7 French system, and if it doesn't work, we can still escalate to ECPella. That would be our strategy, and often. So basically, what we want to achieve when we put in the balloon pump is that at least the aortic valve opens up again. So. And because we don't want to have stasis of blood in the LV, that is our only purpose. I think there is much more research to be done to figure out the best venting strategy. Obviously, the Impella from a concept point of view makes a lot of sense, but you add another 14 French, at least when you use a CP, you add another 14 French. So hopefully, with the newer Impella ECP. That might become a very attractive way of venting.
And you could do this together with a balloon pump. You could do an LA vent and a balloon pump.
Oh yeah.
Yeah, new devices now which go down to 10 French. I think Magenta, and there's another one from Schiefermate. So this will really change.
But the challenge with Impella in a lot of countries is the cost, and it's just
the cost and also hemolysis, right?
And complications.
Yeah.
So 2 questions. One is to Dr. Chul-Min Ahn regarding closure. After you put in ECMO, let's say you have a successful decannulation. I saw a video where you were actually puncturing the cannula and you were actually putting, how do you do it? If somebody could explain that's one thing we would want to know. Secondly, to Dr. Nicolas, you said about using 50 cc pumps. In India, I think the largest IBP balloon available is the 40 cc. We don't have the 50 cc pump. But do you really adhere to the height restrictions when you do that? Or, you could use a 50 cc even, let's say, in a standard height, let's say somebody who's as high as me, or would you really typically want that German patient who's really like 170 centimeters or 180?
Yeah. So above 1 meter and 65 centimeters is a 50 cc balloon pump in my center.
Well, that's pretty standard, actually.
Yeah.
Yeah, but we don't get 50 cc. So do you think that had we put in 50 cc balloon pumps in most patients in ECMO, would it unload really better than the 40 cc?
I think a 50 cc will do a better job than a 40, and this is data that Naveen Kapoor also suggested, right?
And it's unfortunate that all the balloon pump trials use the small ones.
Small ones.
Because it's definitely better.
The IBP-Shock 2 was a 30 cc balloon pump.
How much better? It's hard to tell. Maybe your trial will help us understand it.
Thank you.
You mean the distal perfusion insertion site? So previously, the Professor Yang was showed some images. We punctured the catheter itself and the wire insertion, and then decannulation with a compression, and then we inserted 2 devices, so perclose devices. Yeah, that was the usual method for percutaneous closure. Yeah, 2 program. Yeah.
But it's manual compression on the distal and ProGlide.
Distal usually we had also
you did ProGlide too?
ProGlide or some
Yeah. So you remove the 18 or 19 French sheath or cannula, and then you use 6 French ProGlide.
6 French ProGlide, 2 ProGlide. Yeah. We usually in aortic procedure.
But usually we pre-close. So
pre-close, or some cases we inserted pre-close, elective ECMO, but usually emergency cases we cannot insert it. So we, after the decannulation, during the decannulation, we inserted the 2 devices of per-closure.
That's new for me. Okay.
So there are 2 techniques for doing that. So it's all about getting the wire back in your 19 French or 17 French sheath. So as was demonstrated nicely, you can puncture just the cannula and then insert the wire, or you can do the more complex way. So you first clamp, and then you have these dilator cannulas of 24 French. They fit very well into the cannula of a 19 French ECLS cannula, and then there is no blood coming out, and through that introducer you can then insert your wire. That is for suture-based closure, but I must say that Manta closure with an 18 French Manta is very has been very successful, and it seems to perform better in late closures of mechanical circulatory support. So in Erasmus, it's our go-to closure for impalas and ECMOs these days.
I can immediately understand MANTA, but how does it work with ProGlide? I mean, you have a 6 millimeter hole in the
So
artery.
you take a sheath parallel, you take a sheath parallel and another wire, and that makes the hole smaller. And that
But that's not what they do.
but that's what we do. Then you have a buffer.
So basically, what the simple way is, you once you have your wire in, you take out the sheet. Somebody holds compression, because otherwise it will be quite bloody, and then you insert the first ProGlide.
But the anchor of the ProGlide has not. Its diameter is maybe 4 or 5,
Yeah,
so
so
that means you pull it out, right?
You can. That's the risk. You can. But it works. It works.
Yeah, but the easy way, Horst, is to put an 8 French on the side, and that's a buffer, and that makes it smaller enough to anchor. And then do the same thing.
But the problem of that technique is that you can capture the sheet with the wire.
Which causes a very interesting situation, right?
Yeah.
Nothing's free.
That's it.
I have a last question to Dr. Yang. I wonder your opinion about balloon pump size. Does it matter balloon pump size over 50 or more in Asian population or Korean population? I ask you your experience and opinion.
Unfortunately, I don't experience that 50 cc of IAVP for to unload every unloading in ECMO patient. I know that in Mayo Clinic, the physician apply IAVP via XLR approach and move the patient and receive rehabilitation to bridge it to for heart transplantation.
At that clinic, does the physician consider the body size when considering determining the balloon pump size?
Yeah, it's a very important point between in body size. There is big difference between ASEAN patient and Western patient.
Yeah, absolutely. You can oversize a balloon pump. You shouldn't do that.
Any other questions or comment? Okay, I will thank for the lecturers and the panels and all participants. Thank you very much, and close this session.